In terms of our presentation this afternoon, my focus in the discussion on relapsed refractory myeloma will be on some of the recent approvals in the United States for the treatment of relapsed refractory disease. And these will revolve around, first of all, Pomalidomide-based therapy, Carfilzomib-based therapy, HDAC inhibition, Panobinostat, and then most recently the approvals of Elotuzumab, Daratumumab, and last but no means least, Ixazomib, as the first orally bioavailable proteasome inhibitor to be approved for the treatment of relapsed refractory myeloma. The change in clinical management generated by the availability of these new agents is remarkable in my view. It's quite dramatic. First and foremost, they're novel mechanisms of action. The HDAC inhibition story is a classic example of that as a next generation small molecule strategy, and it's not just Panobinostat, of course, it's the next generation that are coming behind them, behind Pano I should say, in the form, for example, of AC1215-241 and other novel oral HDAC inhibitors. In that same context, the monoclonal antibodies are completely new in terms of mechanism of action. Elotuzumab is a true immunoadjuvant. Daratumumab targets CD38, has monotherapy activity, combined with other drugs is superb. Elo similarly combined with either bortezomib or immunomodulatory treatment is remarkably effective. And then of course we have the next generation immunomodulators, Pomalidomide really proving to be a remarkable next generation IMiD, and then now Ixazomib, which as a second or third generation proteasome inhibitor, depending on how one likes to frame it, it has the real advantage of activity as clearly demonstrated in the Tourmaline trial with clinical benefit, progression-free survival advantage of at least 6 months. But remarkably as well, it's very favorable tolerability profile. So it's once a week oral, it works in high-risk disease, which is particularly compelling, and at the same time, it's well tolerated.